So hello and welcome everyone to the Menopause Symposium, where we bring you new and interesting insights from the world of menopause. My name is Basil Wata. I'm a gynecologist and a menopause specialist in London. I'm joined today with my friend and colleague, Vikram Talolkar, who is another fantastic menopause specialist in UCH London. As we previously discussed, we hope to be bringing you these videos once a month and keep bringing you new and interesting articles and research outputs on different aspects of managing the menopause. So Vikram, today we have quite an interesting randomized trials. It's all focused around CBT or cognitive behavioral therapy for women in the menopause. Perhaps we can start, and this is a RCT that is done by Green et al. And published in the Journal of Menopause. So maybe you can tell us a little bit more about the concept of CBT and how it could be applied to menopause in general.
So thanks for choosing the paper, Basil. Again, very topical because there were recent NICE guidelines open for consultation, which highlighted the role of CBT as one of the options for management of menopausal symptoms. CBT has been around for quite some time. It's a very useful technique. It is used by women or patients who may not be using it for menopause reasons, for mood, anxiety, but it's also come in limelight or focus because it has quite a number of uses in terms of menopause. This particular paper is interesting because it not only focused on the classical symptoms of menopause, for example, how much distress there is from vasomotor symptom, hot flushes, night sweat, but also it looked at the depression, for example, the mental health effect of menopausal symptom, depression, anxiety, and some other peculiar sort of areas, for example, distress from sexual concerns. And all that means that it's much more of a holistic look at CBT application for menopausal symptom rather than just concentrating on hot flushes and night sweats. Of course, it was a randomized trial. And sometimes in this situation, when it's patient intervention, if self-reported intervention outcomes, it's very difficult to conduct an RCT in that situation. But of course, the authors have done well to do a short RCT, which I'm sure you'll go through the details of, and then we'll look at how relevant it is in terms of what happens in our day-to-day clinical practice.
100%. And I think CBT is somewhat overlooked in clinical practice, and a lot of specialists find very limited time, perhaps very limited training and familiarity in how to deliver it safely in clinical practice. So it's important to share the evidence. And as you mentioned, it's a chapeau bas to the researchers for doing this in a very systematized way. So the group is from Canada, and they developed this intervention that they called it CBT Meno, which is sort of bespoke designed for women in the menopause to address physical and psychological menopausal symptoms. And in this RCT, it was a single blind RCT and from a single center. And what they aimed is the randomized 72 eligible women to either the CBT Meno or a waiting list. So, and then they collected their outcomes 12 weeks later. So the assessors were blinded, but obviously it's difficult to blind those who are receiving the CBT, or impossible. And therefore, this is something to bear in mind when interpreting the results of this study.
Yes.
So looking at their inclusion criteria, they involved women who were in the age of 40 to 65. They're in the menopause transition or have been menopausal with a surgical menopause. They have reported at least mild depressive symptoms on the Beck Depression Inventory Scale, which is a very widely used and well standardized depression scale. They're not taking HRT or any psychoactive medications in the last 12 months, and they've been fairly stable. And they did not have any changes in their medications in the last 12 months. And they're not receiving any concurrent psychological treatment. And obviously they speak English. Now, they excluded those with severe depression and active suicidal ideation, which makes perfect sense because obviously those type of patients, you need to summon more sort of advanced help rather than just a CBT program. Now, the choice of outcomes is rather interesting because they looked into, so they did semi-structured diagnostic assessments interviews at the beginning to assess how was the psychological status of the participants. And they also looked into a scale for vasomotor and depressive symptoms, so HFRDIS, which I couldn't find if it was actually validated in this cohort or not, and it was not reported in the paper. On a quick PubMed search, I couldn't really find a validation study for it, but it mentioned that it has a range from 0 to 100. When above a certain cutoff, it will show severe disease. And they also used as a secondary sort of subset the green climacteric scale, which is again very widely used scale in the world of menopause and research. Do you use it in clinical practice? Have you ever come across a setting where it's actually been used to assess menopausal?
So we don't use it in clinics, but it's widely reported and used in many different research papers. We tend to use the menopausal rather than the green climacteric scale.
Yeah. And then for depressive symptoms, they used the BDI, which is again what they were as part of the inclusion criteria. And also they used another subset scale, which was clinician administered. So the difference, which is very important because we will see later in the results, is that the BDI is self-reported, while the Montgomery-Åsberg is clinician administered. And they did the same thing for the Hamilton Anxiety Scale, which is self-reported, and the Pittsburgh Sleep Quality Inventory. And then they used the Sexual Function Index, which again, fairly widely validated and used in the world of menopause. And finally, a client satisfaction questionnaire to see if the participants were actually satisfied with the intervention they received. So quite a lot of qualitative and sort of self-reported scales. What are your thoughts in looking at these outcomes? Do you think other outcomes could have been captured in this?
I'm pretty happy with the range of outcomes captured because usually it's just about vasomotor or just about depression. So they've tried to look at a wide range. Of course, you could always include more, and I think there's no limit because menopause has so many symptoms associated. So you
Right.
could, of course, keep increasing your list. But I think overall, given that they're using 2 scores and sort of wide range of assessments, I would say this is well done.
It is. I think from the angle they focused on, it's quite comprehensive. My only thought would be, we're all heading towards reporting a core set of key important outcome, and I think it would be great if all RCDs in menopause are
That's true.
adopting that to aid better sort of evidence synthesis for the future. So
That's true, Basil.
moving on to the sort of statistical analysis was a decent effort in that they used ANCOVA models and paired t-tests. They did not do a regression analysis to adjust for potential confounders. Again, we would always assume that the randomization adjusted for that, but as we have published and argued that there's in menopause, there's a lot of confounders and effect modifiers that we need to bear in mind when designing reporting such studies. And again, they did an intention to treat, which is quite a good choice in terms of reporting it. They did not publish a pair protocol, which would have been interesting. And the assessor training, they were all psychology graduate level students in clinical psychology that were doing the assessment under the supervision of a PhD-led licensed clinical psychologist. So I think it's fairly robust in that they adopted the same level of training across all the assessors for all the participants. So results, what are your thoughts before we yield into it? In your opinion, do you think it will work?
It should, but interesting to see what the results are.
100%.
Let's go through them.
So the key interesting element is that they did randomize the 72 participants, but as we saw, they suffered from quite a bit of loss to follow-up. Largely, again, I think it's the COVID effect in
the nature of the year.
And so at 12 weeks baseline, there were improvement in the CBT meno, and that they were reporting less current mood disorders. and which was statistically significant. And also the CBT Meno group showed significant reduction in interference due to vasomotor symptoms on the HFRDAS scale, which was helpful. They also showed reduction in depressive symptoms on the BDI scale. However, this was not replicated in the clinician-rated depressive symptom scales. So the changes there were not statistically significant, which is quite interesting and, yield to the element of what is the, self-interpretation of
Self-reported.
improvement. Exactly. And they looked into the other secondary outcomes. There were some improvement in it. So those who had the CBT showed lower sleep difficulties. They also had reduced sexual concerns. But on terms of anxiety and sexual concerns based on the FSFI, there were again no major changes on that level. The interesting bit, which always you'd think about, is that how long would a five session CBT intervention yield in terms of benefit? And interestingly, they did show some maintenance of the benefit up to 3 months, but there were no statistical significantly changes in the symptoms they were reported between the baseline and 12 months. And then most of the participants were actually quite satisfied with the intervention that they received. So, what do you think of overall the results? Convincing, not convincing?
Well, convincing in the sense that this is what we see in the clinical practice, isn't it? In the sense that not everyone will benefit from CBT, but there'll be a group of women who will really find CBT as a very good option. You find that some women have a long-lasting effect of CBT. They continue practicing CBT for months or years and get benefit from it. Others find it's not something sustainable, then they would still have to consider other option. So kind of you get the same sort of feeling from the trial, is that it's a valuable option for some women where it will work well, but not for everybody.
Yeah, I agree. I think it's not an easy trial to pull off, and they did a very good job in terms of reporting. As we discussed, some of the limitations that we've sort of alluded to is that there was a lot of self-reported measures, and sometimes you'd like to see some clinician validated or at least objective measures that goes to show and sustain the benefit from CBT. Of course, no single trial is perfect, and that's something you could aspire to, and that's exactly what happened. Is that in the clinician-based reported depressive measure, there was no
difference,
significant improvement. And again, they suffered from significant dropouts, which slightly reduce the sort of generalizability and validity of the study. The choice of waiting list, I think that's quite interesting. I don't know what you think about that as a comparator.
Yes, I think it's very difficult in these situations sometimes to make women wait, especially if they're having significant symptom. 12 weeks is a long enough wait sometimes. So perhaps it would have been good to choose another comparator, either a medication or some other form of CBT-like therapy. I think the authors do kind of allude to that in their paper. And that's probably the next stage of research with CBT, comparing it to an active treatment.
Yeah, 100%. I think perhaps if there was sort of a common advice or lifestyle intervention that is given to both groups and sustained for the control group, while the intervention group got on top of it, the CBT Meno would have given a little bit more sort of deeper insight on the actual effect of the CBT Meno in this case, and potential benefit from it. But there, as you said, there's so many different ways to sort of how to design such RCTs. I agree. So overall, I think this is a nice, snappy sort of publication that goes to add to the body of evidence that is saying CBT is probably beneficial for women in menopause. But as you mentioned, it's all about right selection of the patient and who would benefit from it more, and who might not see that much benefit. What do you think is next step in terms of what future research we need, and how can we adopt it into clinical practice?
So as we discussed, Basil, so one of the things is, can we do longer trials? So this is just 12 weeks, 3 months. But of course, the biggest criticism will be it's short term. 3 months is still very small time period. Do we have evidence that 1 year, 2 year, 3 years, somebody can sustain and continue this? We need a longer term trial. We need it in separate groups of patients. So the good thing here is this is in women without any background medical issues. There are other trials, say in breast cancer patients or women who don't want to or cannot take HRT. CBT is very valuable there. There are evidence, trials which show evidence that it's effective. But again, we need to do it in bigger groups, specifically targeted groups. And then finally, of course, most women who did the trial were very happy. They said almost 100% of them said they would recommend it to somebody who was in their situation. So that shows that it's a very safe, effective, and acceptable therapy. There are no side effects like for HRT risk or side effects of antidepressant. This one doesn't have any medication side effects. So really a very useful, simple option, which can be used side by side HRT or antidepressant. Why not combine it as a sort of holistic approach? So all those aspects can be studied in future.
I agree. I think a very interesting one would be to see the true effect of CBT as a complement treatment to HRT and as a
Correct.
standalone non-HRT option for those who cannot take HRT. And a
Indeed.
sort of a multi-arm, multi-stage sort of trial would be an ideal sort of methodology for to really elucidate that. But that will be quite a complex endeavor to take. So I don't think we'll see that for a few years to come. But definitely quite an interesting finding, and I think we should, as clinicians and menopause specialists, we should probably adopt CBT more into our practice and
Definitely.
help guide the women on how to initiate it, because anyone can nowadays, with the use of an app or internet-based intervention, can initiate it and maintain it, but they always need the help and guidance of their menopause specialist.
Yes. One of the criticisms of NICE was that they recommended CBT, but it's not available on the NHS. You have a very long waiting list. It is available, but a long waiting list. It's not easily available. So I think hopefully now that the awareness has been created, there'll be more resources. And as you said, there are now resources on apps, internet websites, good reliable platforms and portals offering this. So hopefully it will pick up the pace and more women will get the option reasonably quickly if they wish to try CBT.
100%. Right, I think that's the end for this session. Thank you everyone for joining us for today, and looking forward to have you all back on future sessions of the Menopause Symposium. As before, please subscribe to the channel and on our newsletter on the menopause.co.uk website. We'd love to hear your comments and your requests for any specific intervention or research article, and see you all in the new year.
Thank you,
Thank you,
Basil.
Vikram.